Irene Beru. Dr. Irene is the head of unit for clinical pharmacy. She's also oncology pharmacist by subspecialization. Dr. Irene, welcome to today's session. How are you?
Thank you, Dr. Amina. I'm fine, thank you.
Great. So I can see we have quorum and we can start our session. Then, as usual, if you have any questions, address them on the Q&A. If you have any concerns, you can put it at the chat box and we'll have the question and answer at the end of the session. Thank you. Over to you, Dr. Irene.
Thank you, Dr. Amina, and welcome everyone to this afternoon session. So our title today was Medicine News. Just a moment, sorry about that. Okay, so sorry about that. So we are going to look at, I needed to go to my first slide. Unfortunately, just let me just stop sharing. Or is someone else sharing? Sorry about that.
Dr. Beru?
Okay, so sorry about that. I think I'll just move on. So unfortunately, the first slide is not showing. All right, so that's the topic of our presentation. Today, we are looking at medicine use, optimizing patient outcomes through collaborative practice. So our objectives today are to provide an overview of our medicine management cycle. And then we're going to highlight opportunities for collaboration in medicine management and use, and create awareness on medicine management and use. And finally, just stimulate discussion on best practices. So on the overview of the medicine management cycle, I think especially the pharmacists joining us today are familiar with this. So we have selection, and I will go into detail a little bit later on selection, but this is basically where we choose as an institution or as a country what are the medicines that we're going to be using. And then the next step is procurement. But between selection and procurement, usually we will have quantification, we will have budgeting, and we will look in detail at some of the things we do during budgeting and quantification and opportunities for working together. And then we procure the medicines, and there are different laws and different institutional policies that govern procurement. And then we look at distribution, and finally we look at use, and we will focus a lot more on the use of medicines. All these are anchored on policy and legal framework, and we have institutional policies, we have national policies as well. So in terms of medicine selection, the key considerations in terms of medicine selection are that medicines are selected based on need. So for example, the medicines that we select for use at Kenyatta National Hospital are not necessarily the medicines that are county referral hospital would be selecting. There may be some differences based on the patients that we see as an institution, as well as patients that other facilities would be seeing. Then the medicines of choice are selected. What does that mean? It means that if you're looking, for example, at anti-diabetics, and you're looking at sulfonylureas, you will not select all of them. You will decide which of the sulfonylureas is going to be our choice medicine to be used within the institution. Then you consider the efficacy and effectiveness of the medications that you're choosing. You look at safety data that is available. You will be looking at the cost and the quality. And when we talk about quality, sometimes that is tied to what is available within the setting that you're working in. If the medicine is not registered for use within your setting and you've put it on your list, it means that you will most likely be depending on parallel imports, and then you cannot assure quality for those products. And then in the selection process, you always have to provide for the use of non-formulary medicines, and the institutions will have processes and procedures in place for how different medicines will be acquired on named patient basis, for example. And then in terms of combination, fixed dose and products, those should be used mostly in situations where you have proven benefit for specific conditions. And then the medicines that we select need to be consistent with national and institutional formularies, as well as standard treatment guidelines. So those are some of the considerations that we put in place when considering inclusion of medicines on a list. So what are some of the available resources that we have within our reach? Most institutions will have their own formularies. For example, KNH has an approved medicine list. When we talk about formularies, for those who may not be familiar with the term, we are talking about an approved list for use within the institution. So KNH would have its own formulary. There are hospitals that have their own medicine formularies. I know Yala, sub-county hospital, has their own formulary. We have other institutions that are having their own formularies. Then we have the Kenya Essential Medicine List. That is what all our institutional formularies should be anchored on. And then we have disease-specific treatment guidelines that guide us in terms of what are the medicines that we should include on our medicine lists. Who's responsible for selection? Selection should be done by the medicine and therapeutics committees. And at the national level, we have a medicine and therapeutics committee that has members drawn from the ministry as well as from institutions at different levels of practice. And then it always has to be multidisciplinary so that it is not a pharmacy only activity. It is a multidisciplinary activity where all the there are representatives from the different specialties and disciplines. And what is important is that the healthcare workers need to participate in terms of deciding what should be included on the list. Formularies are living documents. What that means is that formularies, they change with time. You may find that there is a new ADR that has been reported for a specific medicine. And when that happens, then that medicine will no longer be on the list, or its indications on the list will change. So it's a living document, or there will be new medicines registered for different indications, and you could include them on your list if you did not already have them on your list. Then the next step after you have selected what medicines to use is that you will quantify. And when we talk about quantification, this really includes forecasting and supply planning. And it includes the decisions on how much should be procured and the costs included in procuring these products. And then when should the products be delivered so that you avoid situations where you have stockouts. The considerations in quantification, forecasting and supply planning include the expected demand for the products, the unit costs of the products, because the unit costs are what determine the overall cost of the products that you're going to procure. And then the existing stock. So if you have something on stock on your shelf, then it means it will affect how much you're going to forecast to procure in the coming days. And then there are stock on order, like if a supplier already has a pending LPO, that's a local purchase order, then that will also determine how much you will plan to procure. And then the lead time, how long does the supplier take to deliver the product to you? And then the maximum and the minimum stocks that you have determined to have. Then usually quantification will be based on historical data, consumption data especially, or the services that an institution provides. It would also be based on mobility and demographic data. And then you will usually have assumptions that you make for future demand. So when you look at these considerations, you see that there are considerations that affect different departments. For example, the expected demand. Pharmacy would need to work very closely with the prescribers to see what are the expected demands. And then in terms of stocks on order, existing stocks, the minimum and maximum stock, this would need to be determined alongside the supply chain departments. So as an example, in KNH, we have several pharmacies, and we usually will do 2-year tender cycles within KNH. And we will usually be working within the government timelines to have annual budgets and also the midterm expenditure framework. So these are what we consider when we are doing quantification. And usually as KNH, we would be asking the individual pharmacies to quantify, and then we consolidate the quantities that the individual pharmacies have quantified. And usually it depends on historical data. So we will, including the average monthly consumption. And the assumptions that we make include services that are expected. For example, if we expect to expand critical care units, then the medicines to be used in critical care units will be quantified to meet that expanding demand. Right now, I think what we are expecting is that there'll be the implementation of the referral system, and some commonly prescribed medicines may have their quantities reduced because there will be reduced demand for them. Then morbidity data is especially important when considering new medicines, and this is critical for us during this time because we have just reviewed our formulary and we'll soon be sharing a published copy. So for new medicines, we will use morbidity data. And then usually we use what is called an ABC analysis to help us doing the rationalization of the budget, and we'll discuss a bit of that later. So this is an example of an AMC. It is not meant to show for you to read really, but just to show that within our settings, especially like at KNH, we have been able to look at AMC's average monthly consumption, and we are able to monitor different products. And I've just highlighted an example of an AMC from an oncology unit, highlighting a few products. And you can see that we monitor trends. And what that means is that we are looking at increase in consumption. So like whatever you see marked in red, it means those products, the consumption has gone up. And then whatever is marked in yellow, it means that the consumption has decreased. And we manage this on a quarterly basis so that it can help us to see whether there are any changes in trends. Because if we have changes in trends, if consumption has gone up, it means we will need to be asking for review in the budget allocation to procure the increased quantities. And if the consumption is going down, then we need to be looking at, is the consumption going down because the treatment guidelines have changed, because the patient numbers have gone down? And of course, we would need to be reviewing that so that we do not have expiries on the shelves. This is important, especially when pharmacy is working with supply chain. The next item that we can use in terms of monitoring and helping us with quantification is what we call the ABC analysis. And when you look at an ABC analysis, medicines in brief are categorized into 3, the class A, the class B, and the class C medicines. So the class A medicines are usually few medicines, about 10 to 20 items, and they will take up about 10 to 20% of the items, and they will usually take up about 70 to 80% of the expenditure. So they are few items, but they take up a big proportion of your budget. The B items are average, and then the C items are what we use for common diseases. They are the costs are minimal per item, and usually they will take up only about 5 to 10% of your expenditure or of your budget, but they will be usually between 55 and 85% of the items. So like in looking at KNH, for example, in 2018, 2019, our total items that we procured were about 635. And of those items, 125 of them took up 80% of our budget. And then about 347 of those items took up 5% of our budget. These are the low-cost medicines like paracetamol or other commonly prescribed medicines. And then in 2020, 2021, our total number of items procured was 798. And our A items were 169 items, but they took up about 75% of our budget. And our C items were over 380, and they took up about 5% of our budget. So when you look at which of these A medicines we are procuring from year to year, you find that there are some common medicines. So like looking at the like 2 years, like we skipped 1 year in between, but 2018, 2019, these are our top 10 items that we procured. They took up so much of our budget. And then when you look at the 2021, 2022 projection as well, it shows us which items those are. So this is basically supposed to help us see that we are monitoring and that you can also see a trend. For example, if you look at 2018, 2019, we had trastuzumab as our highest cost item. That took about 5% of the budget on its own. And then we have projected that in 2021, 2022, it was going to be our top item. The question is why in 2020, 2021, it did not take up a big proportion of our budget. And that's because we got it under the UHC, so we didn't use the KNH money directly. So this is basically just to show which items you have opportunity to make great interventions on in terms of monitoring for stockouts, in terms of negotiating for better prices with suppliers, as well as looking at whether or not some of these items can be managed within standard treatment guidelines so that we make sure that we manage our budgets well. So when we look at our projection, this is just basically supposed to show us about the top 20 or so items that we have projected in this coming year to use a lot of our monies within the institution. So for example, trastuzumab that is used for breast cancer was supposed to take about 5.1%. But again, I've mentioned that these are items where you can have great interventions in terms of cost management. So for example, we have recently received a price reduction for trastuzumab. So when at the end of this year, we do our ABC analysis, we may find that trastuzumab is no longer one of our top 10 items. So when you look at quantification and budgeting, hospital managers play a key role in terms of resource allocation. And there is great opportunity to collaborate with management in terms of how much money is allocated to pharmacy so that we can have medicines available and at the time they are required, and that resources are available, especially for critical medicines that are high cost and which have a great impact within the budget. Other important collaborators include finance, because finance are the ones that manage the resources within institutions. The prescribers are great collaborators when you're looking at your quantification, and that's because they're the ones that will write these medicines for patients. And we have opportunity, especially to work with prescribers to manage our Class C medicines, to manage our Class A and B medicines, and preferably use Class C medicines, because the Class C medicines that are low cost can be used for majority of the patients. And if we mostly use the Class C medicines, then it means that most of our patients will get the medicines they require within the institutions, because these ones, the costs are quite manageable. And then in collaborating with partners, we have opportunity to have price reduction, as well as access programs, especially for Class A medicines. And then collaborating with supply chain to make sure that we are managing our stocks well so that we avoid stockouts. And pharmacy, of course, has a key role in terms of monitoring and giving feedback. Okay, so after you have quantified, we move on to procurement. And in terms of procurement, just a reminder that for public sector, we are guided by applicable laws. and that it's important to always have your reorder levels, and there's the role of supply chain management and finance in terms of managing our reorder levels and making sure that we procure in good time and that suppliers are also being paid in good time. Then we need to always align quantification, procurement with our quantification and make adjustments as need may be. And then pharmacy monitors critical medicines on a daily basis. So we will share a little bit about what we do with what we call tracer medicines. And then there needs to always be timely feedback from suppliers so that if suppliers, and I know there are some that join us on these webinars, then they need to communicate in good time when they don't have stocks available, or to communicate in case there are any changes in terms of lead times, because this helps us in terms of planning and making sure that patients do not miss medicines when they are prescribed. So I've mentioned that in pharmacy, we do what is called tracer medicines monitoring. These are basically medicines that we consider critical per pharmacy unit, but we monitor these on a daily basis, and then we consolidate this data at the end of the quarter. So it helps us to also compare with the prescription order fill rate and to see whether there is any relationship within our, between our prescription order fill rate and the non-formulary prescribing as well. So you can see the blue basically shows us the tracer medicines. On most occasions as KNH, we are at about 80% availability of the critical medicines that we are tracing. And then the prescription fill rate is quite comparable to our tracer medicine list percentage availability. And then our non-formulary prescribing is minimal and can account for the difference in terms of the prescription fill rate. So in terms of distribution, this includes distribution from suppliers. It includes inter-hospital distribution as well as bulk and individualized dispensing within the institution. So this distribution is important because suppliers, especially when supplying products that are heat sensitive, that require cold storage, need to make sure that the cold storage is maintained throughout the supply system. And then we have a lot of inter-hospital distribution of medication from from Kenyatta to other hospitals, as well as other hospitals to KNH, and we monitor this closely. And then important to remember that storage conditions are monitored throughout the supply chain process. So we do temperature monitoring and humidity monitoring, and we have the hygrometers as well as the thermometers to monitor this. Then we also do ward and store inspections so that we make sure that medicines are stored according to the requirements by Pharmacy and Poisons Board, as well as institutional requirements. And then important to note that there's a lot of redistribution that is done, especially between hospitals, to avoid wastage. And that has been something that's been happening a lot because the pharmacists are working together on a daily basis to just share information on what is slow moving within their institutions and sharing that with other pharmacists in other institutions so that we make sure that we are minimizing wastage. Then in terms of use of products, this includes prescribing, dispensing, administration and monitoring, as well as product manipulation and compounding. And there are special considerations for narcotics and psychotropics and other high alert medicines. So in monitoring, we look at pharmacovigilance, which I think we've done previous sensitizations on, where we document poor quality medicines and adverse drug reaction documentation. And this is the responsibility of everyone, from the prescribers, the nursing staff on the wards, as well as the pharmacy staff, especially the clinical pharmacists attending rounds or going to the patient bedside. But patients also have a responsibility to document poor quality medicines as well as ADRs. And then we have medication error documentation, and I think there's already been a sensitization in the past on this. And most important, we always have to monitor clinical outcomes for the patients. I think sometimes we do not document clinical outcomes for patients, and it's important for us to do this as we continue to monitor patients, so that if medicines are not working for patients, we are able to change the treatment plan so that the patients can benefit. And then in terms of product manipulation and compounding, there's opportunity for non-sterile compounding, and we do a lot of extemporaneous compounding, especially for pediatric formulations that are not commercially available, but we are able to prepare so that patients are able to get treatment that they require and they can respond to their treatment. Okay, and then I will look at prescribing and dispensing in a little more detail as we move along. I don't know if one of the panelists, Amina, Dr. Amina, can check on the hands that are raised. There are quite a number of hands raised.
We can do that at the end of the session.
At the end, okay, that's okay. All right, that's okay. So these are sample prescriptions, and the reason we put these prescriptions here is just basically to highlight that sometimes prescriptions are incomplete. And when you have incomplete prescriptions, it means that we introduce opportunity for errors, and this can affect patient outcomes. On many of the pharmacists forums, especially on WhatsApp, we always have like a prescription shared and different pharmacists asking their colleagues or asking our colleagues to help identify what may have been prescribed. So when you look at those 3 different prescriptions, you can see that one has very clear handwriting. It has 1 or 2 missing information, but basically the handwriting is very clear. But we have the other prescriptions where there's a lot of scribbling and it's very difficult to actually decipher what it is that has been prescribed. So in 2018, one of our colleagues did a study, that's Dr. Kavita, and looked at our own prescriptions within KNH. We've just highlighted 1 or 2 aspects from what she picked. And we found that most of our prescribers, about half of our prescribers, really not most, prescribe medicines by their generic name. So you can imagine where the brand name that has been used is not familiar, then there's a lot of guesswork happening and a lot of consultations happening, and that is quite time wasting. So we have medicines that are prescribed by generic names and across all cadres. In KNH, we have coded prescriptions. So you can see that across all cadres, we have about half of the prescriptions prescribed in their generic name or in their international nomenclature name. The SHOs, the medical officers, the dental officers, most are the ones that do a little better, but they are also about 55%. And then in terms of formulary prescribing, we were over 90% for most of the cadres. At our clinical officers and our interns mostly had about 87% formulary prescribing, so gives us an opportunity for intervention. So when we looked at some of the errors that we saw in terms of omission, errors related to medicine information, we found that most in the outpatient setting, about 58% of the prescriptions did not have route of administration. Maybe there's an assumption that this is an outpatient setting, so it is obvious that the route of administration is oral on most occasions. And then the dose was not indicated for a very small proportion, but you can see that the blue prescriptions for the clinical officers as well as interns had about 12% dose not indicated. And then in terms of not including frequency, most prescriptions had frequency included. We had about only 1% did not have frequency indicated. And then the duration of treatment is mostly indicated for most of the prescriptions, but we have opportunity to make improvements for our medical officers, dental officers, as well as our registrars. Some of the factors that contribute to errors are sound-alike medicines. In prescribing, in dispensing, these are very common contributors to errors. Then poor handwriting. We have seen 3 different prescriptions, and 2 of them we have seen have quite a bit of scribbling. So poor handwriting contributes to errors at dispensing as well as at administration. The use of abbreviations is also a problem. But I think in a teaching hospital, unclear verbal communication becomes a big problem, especially where we find ourselves doing ward rounds, and then at the end of the ward rounds is when our doctors in training in the wards are writing the the prescriptions for the patients after the ward round. Memory lapses is also common, especially if you're trying to do your notes at the end or you're trying to write your prescriptions at the end of the round. And then the large volume of medicines in use. We have seen that in one of the years, we procured close to 800 items, 800 medicine formulations or different strengths. And this is a large volume of medicines, and that's not even all the medicines in the market. So I think this really contributes to errors. And then poor and incomplete documentation is also a problem that contributes to errors within our setting. So we'll have a discussion at the end, but in terms of policy and legal framework, we have many Ministry of Health documents, and some of them include the Health Products and Technology Supply Chain Strategy. And then we have several acts that really govern, especially in the public sector, what it is we do, like the Public Procurement and Asset Disposal Act is one of the ones that guide us in the public sector. We have the Pharmacy and Poisons Act, we have Narcotics and Psychotropic Substances Act, we have the KEMSA Act, and of course, we have the Constitution that guides us in terms of how we manage medicines. So what's our application and conclusion? We have many opportunities for collaboration, and I hope even as we have listened to this presentation today, we have noticed some of the opportunities. If we are in nursing, we notice some of the opportunities we can use in terms of collaborating, especially like in monitoring patients, especially for ADRs. Documenting poor quality medicines is an opportunity for nursing staff. Our prescribers, we have opportunity to collaborate, especially in making decisions on what should be included within the institutional medicine list, as well as in terms of monitoring and making choices to use medicine so that we can manage the costs of healthcare. And then communication is important. This we can never overemphasize. So if we are communicating as a team, then we are able to work together well if we understand what what we are doing in our different scopes of practice. And then medicine use is not a pharmacy only responsibility. We've seen that we need to involve management, we need to involve finance, we also need to involve our supply chain colleagues. And then medicine use is complex, but it requires teamwork. And if we're working together as a team, then we are able to make sure that our patients benefit and the patients get better outcomes if we work together. If supply chain works together with finance and works together with pharmacy as well as the prescribers, then our patients can get medicines in a timely manner and we are able to meet their needs together. Thank you for your time, and we will take questions and have discussion. We have a rich panel of pharmacists as well as prescribers, and we should be able to take any questions after this. Thank you. Dr. Amina, back to you.
Thank you very much, Dr. Ali, for that very informative. There's so much that I've personally learned. There's so much that I have personally learned on the pharmacy and areas of collaboration. I think on my end, I usually have this thing of complaining, this drug does not work, this drug doesn't work, but never have I ever filled something to actually respond for feedback to the pharmacy department. Maybe any of the panelists, any comments from the panelists before I talk to the people who've raised their hands? Dr. Berici?
Thank you, Amina. Just to indicate that the department is committed to providing medicines of the right quality, and that we are available to collaborate with the other healthcare providers in the hospital to ensure that patients derive the optimum benefit from their medicines. Thank you.
Dr. Ewa?
Thank you. Thank you very much, Dr. Weru, for that elaborate presentation. I'll just say we just encourage those who are following hopefully we have healthcare workers across the cadres, that we support the optimal use of medicines by at least playing our role, whether it's in selection, and Dr. Weru had highlighted, even if you're in finance or supplies, there's a role that you play in proper selection. And where we have challenges with regards to quality issues, or we note issues regarding either medication errors or adverse drug reactions, we need to communicate that, and we use those to be able to learn and improve our systems. So thank you very much.
Dr. Kinuthia?
Thank you, Dr. Amina. Not much really to add. What's going through my mind is that we have different policies that have been developed in support of appropriate medicine use. And I think we need to look out for these as they are distributed. We have the prescribing policy, the AMS policy, guidelines on antimicrobial use in surgical prophylaxis, among others. So just to support what Dr. Weru and Dr. Birichi have said, the division of pharmacy is willing to support as we implement the right standards on use of medicines in the hospital. Thank you very much.
Thank you very much. Kindly post your questions on the Q&A session. Please allow the people who have raised their hands to speak. Nelson. John Gatabaki. Dr. Thidius Owiti, I can see you're able to speak. You and John, any of you can raise your concern or your comment. John Okomba, yeah. Dr. Thidius, welcome. How are you? Hello?
Hello.
Yes, Okombo, how are you?
I'm good, Dr. Dorothy. Good afternoon. Thank you for a good presentation. I have a question with a concern with where I do my work. Hello.
Yes, we can hear you. We can hear you.
Yes, I have a problem with the quality of the number of prescription I normally receive in my place. I don't know whether there's a policy guiding the prescription and the prescriber who are writing the prescription, because some of them are illegible, you can't see them. You have to share the prescription to another group so that somebody can help you to get whatever is there to avoid error and maybe what may be caused by misinformation there. I'm just asking, is there a policy guiding the need of prescriptions so that we don't have to avoid so many errors and omissions in them?
Thank you, John. Sorry, you have a lot of background noise. I think we can mute. Thank you, John. Just to repeat, in case anybody could not hear because of the background, he's asking regarding what do we do? Is there policy guidelines for the prescriptions that people are not eligible or you can't see or it doesn't make any sense? Dr. Weru or any other panelist?
So we have a prescribing policy within Kenyatta that was recently signed as a hospital policy. But even without the prescribing policy, I think there are principles of good prescribing. And as highlighted earlier, that one of the reasons for medication errors is illegible handwriting. So I think it's just good practice for the prescribers on the call to put every effort to write legibly and to write using international nomenclature names so that there is no guesswork within the pharmacy spaces. Institutions that have been able to implement to digitize their prescribing. That has worked very well. So we are hopeful that in KNH in the coming days, really soon, we will have our ERP implemented, which is where we will have our prescriptions typed in, computerized. I'm trying to, for the benefit of our listeners, some of them may not be very familiar with the terminology, but we will try and use a computerized system to do our prescribing. And I think that will really help to reduce the medication errors, because the prescribers will not be required to write out their prescriptions, but we will have everything typed out. So that can help. But in the absence of that, is to encourage our prescribers to write as well as they possibly can. I don't know if my colleagues have something to add.
Any of the panelists? It's interesting about the ERP. I like that solution. I think also people will be limited in the formulary. It was quite interesting that people are prescribing according to the formulary of KNH. Why do you think that was the case, as opposed to having a very low percentage of 50 with the 90% with the formulary? Is there a specific reasoning towards that, Dr. Weru?
Sorry, Dr. Amina, please come again.
The study for Kavati et al. I had noticed that with the writing generic names, it was 50% average, but prescribing based on formulary was better. It was almost up to 90 to 80%. So I don't know, is there a reasoning behind that people prescribe what is in the formulary, but they do not write the generic names? Is there a reason behind it?
Oh, that's an interesting one. I think many of our prescribers, especially the ones, the registrars in training and our clinic officers, many of them will write using a brand name or the company name of the product, but within a government setting, we usually will dispense the molecule that is available. So I'll use the example of paracetamol. If you write Panadol on the prescription, we will give the paracetamol that is available on stock. We will not tell the patient that the medication is not available. So I think there's a bit of medical representative influence, but there is also the issue of sensitization. We've been trying to sensitize. We provide, as pharmacy, medicine availability lists to the user departments. So for example, the pharmacy that serves most of our outpatient clinics will do a list every 2 weeks of the medicines that are available within the pharmacy. In oncology, we do a list every week. And then in the inpatient pharmacies, we do a list every 2 weeks. So that helps in terms of prescribing what is on the KNH list, but it doesn't necessarily mean that the products will be prescribed in their international nomenclature name. I think also the names look difficult. I've had some of the prescribers say that those chemical names are very long and complicated, but I think it's important for us to basically prescribe using the international nomenclature name. Thanks.
Thank you. So a comment from one of the members, he's asking, why don't we have the list of drugs being available in the hospital on hospital pharmacy websites? Any of the panelists?
That's a good challenge. I actually just looked at the repository recently, and what's there for pharmacy in terms of the repository is very limited. That's a good challenge, and we are committed to providing the updated formulary list on the KNH website as soon as it is ready. We will also be working with our colleagues in medical research to make sure that the policies that we talk about, especially the ones on antimicrobial use and the prescribing policy, and the guidelines like the surgical prophylaxis guidelines are all uploaded so that they can be quick reference for our prescribers as well as our colleagues and members of the public who may want to see what we have in KNH.
Thank you. Mildred is asking, she made a comment, great presentation, very informative. can we have all cadres refreshed on good prescription practices annually as part of the performance appraisal? That's the question. Can we, it's also another challenge, I'm assuming, if we can be having more sensitization.
That's a good challenge. Actually, on the pharmacy division for this year, we have a challenge to, one of our targets this year is to sensitize, especially the prescribers within the KNH space, that's the UoN as well as the KNH employees, on formulary management. And of course, that includes good prescribing as well as good dispensing practices, because the prescribers can be sensitized, but we also have at the same time to sensitize our dispensing staff and our nursing staff. So that's something we are committed to doing. And I think I will respond to that alongside the question on where one can get the prescribing policy, the AMS policy, and the surgical antibiotic prophylaxis guidelines. That's what we've just talked about, that we are committed to making sure these documents are available. And we will be working with our colleagues in medical research to make sure they are uploaded on the KNH repository so that they can be available for anyone who goes onto our website. Thank you.
Thank you, Dr. So Dr. Peter Ongwai is asking, a few drugs are expensive that have been categorized as class A. How many patients percentage benefit from this class, and how do we rationalize this model compared to a more equitable one? Have you understood the question, Dr. Weru?
Yes, I have. Let me ask Dr. Ayuak, who I am seated with, to help me respond to that question. So let her just respond.
So thank you. To respond to that, we want to appreciate that KNH is a specialized care facility. Therefore, their conditions will manage in the hospital. That chances are there may be nowhere else for the patient to go other than a private facility. Therefore, to manage these conditions, we may require molecules that are expensive, but we cannot turn away our patients because we are saying we're only keeping class B, the cheaper drugs. We still have to take care of our specialized clients. So that's why you will see us still having the class A to meet our obligations. Thank you.
Thank you, Dr. So there's a question on erratic supply of drugs. How would you want to address that question? Why do we have an erratic supply of drugs? And why do we get that out of stock? I'm sure there are more reasons than there's no money. So maybe you can elaborate on the reasons. There are many other reasons, so maybe you can elaborate on that.
I'd like to ask the Director of Pharmacy at KNH, Dr. Birichi, to help us to respond to that question.
Thank you, Amina. Just to answer that, I'll take you back to the process of medicine selection, that the hospital will not select all the products that are available in the market. So one of the reasons why medicines may not be available in our facility is if it was not selected. The other question after selection is going to our procurement process. You said that money is not always the reason, but we do appreciate that resources are limited. So the budget we get, we also rationalize in terms of what is available to procure medicines. The other key reason is on supplier performance, that we do a tendering process where we contract suppliers to supply hospital with medicines in case they are not able to perform because of reasons out of the scope of the hospital. Like during the COVID pandemic, there were a lot of disruptions in the global supply lines. So we had a lot of issues with the medicine supply. For those who follow current news, like India banned export of certain medicines to the rest of the world. So this did affect availability in the hospital. The other issues are internal, and that is to do with the reorder levels that we do operate a largely manual inventory management system. It means that there are instances where medicines will run out without the procurement process being initiated. So late initiation of the procurement process could also result in medicines not being available in the facility at certain points. I think those are the major reasons why we may not have certain medicines at particular times within our facility. Thank you.
Thank you very much, Dr. Birichi. Any of the other panelists maybe would want to add on that point? Okay. Any of the people, like Dr. Owiti, are you still with us? Do you want to raise your issue or concern? The people who've raised up their hands, Gatabaki, Serotich. While we're waiting, Dr. Weru, I'm sorry, I lean on oncology. For instance, on areas of collaboration, do we have scenarios whereby the oncologist, together with your team, based on the guidelines and protocols with the cancers that we see mostly in Kenya, do we have that collaboration where they tell you, oh, because we normally see a lot of, let's say, lymphoma, we will require now the ABVD, such discussions? Do you have such collaborations in the hospital?
Okay, thanks for the question, Dr. Amina. We have collaborations with the oncologists, and we work very closely with the oncologists, where we have pharmacists attending rounds, as well as participating in the tumor board meetings. And we also have discussions, especially whenever we want a new product procured or a product procured on a named patient basis. So that happens a lot in oncology. And I think it's the prototype for collaboration, especially within the hospital. It's just that this was an open discussion, so we didn't focus too much on oncology. But that is one of the areas where within KNH, we have worked very closely together. And over the last few years, if you look at our trends in terms of new products being procured, in oncology, we have so many new products that have been procured, and that's because of just working together with the oncologists. In addition, the pharmacists review prescribed treatment, and the prescribed treatment, when we talk about prescribed treatment, we look at the protocol against a published protocol, we look and against the patient's diagnosis. We also review the patient lab works, like the full hemogram and the UECs. We help in those calculations. We also help to recalculate body surface area, especially that's important for dosing in oncology. So the pharmacists are working very closely with the oncologists and with the nursing staff in the clinical areas in managing the oncology patients. The prescribers, when it comes to the choice of treatment and the products to be prescribed, and then the nursing staff, especially in terms of monitoring patients who are already on treatment, especially when we have the infusions running, and we are monitoring for any ADRs as well as any reactions, because we have quite a number of items, products that cause reactions in oncology. Thank you.
Thank you very much, Dr. I'm sorry I picked on oncology. I think it was an easy example. Sorry, I think it was an easy example. Interesting questions from the forum. They're asking, when procurement is done within 2 years and the drugs are over, before the 2 years are over, what happens? maybe the supplier had overpromised. What happens?
So as much as we are saying our tendering cycles are 2-year tender cycles, we actually procure on a quarterly basis, but we also monitor the stock in place. That's why we said we are doing daily monitoring of our critical medicines. So we procure as and when required. At the same time, we highlighted the need for collaboration with our suppliers so that the suppliers can communicate in a timely manner. Like if the prices have changed, if they are having challenges in terms of receiving their stocks and the lead time has changed, and we have that communication. That's why we highlighted it in the presentation that we need to have timely and open communication with the supplier so that we can minimize the times when products are out of stock within the hospital pharmacy. So I think we are constantly communicating, and we don't procure the entire stock for 2 years. No, you quantify and you forecast for the 2 years, but then you procure as and when required as you continue to monitor. And our procurement usually is on a quarterly basis when you look at our procurement planning. Thank you.
Thank you very much, Dr. Weru. Somebody has asked a very interesting question, and if it's okay with the pharmacy team, I think this is a subject of contention that probably would need a webinar of its own. We didn't touch on DDA's inventory. Maybe we can have a brief discussion on that, but I would really, really prefer if we have a whole topic on DDA. Over to you.
Yeah, I think one of the things we tried to do today is just highlight a few areas in terms of medicine management. And you remember one of our objectives was to stimulate discussion on best practices. DDA's inventory is very critical, and it's one of the areas where we need collaboration. We did not highlight those prescriptions that have challenges, especially because this is an open webinar. But we will be working with the teams on the ground, especially in the departmental DQACs. For example, our pharmacists in pediatric wards will be liaising with the team in pediatrics. We have a clinical pharmacist on the surgical floor who will liaise with the surgical team so that we can specifically address the concerns in terms of DDA, not just inventory management, but also in terms of good prescribing practices for the narcotics and psychotropics. I don't know if any of the other panelists wants to comment.
Thank you, Dr. I think that's quite precise. And I hope I get a volunteer to talk on DDA. Somebody has made a comment, Sylvester has made a comment. Why do the pharmacists in the hospital dispense some drugs which require evidence of culture results as per dispensing policy of antibiotics? I think generally it happens in many hospitals. Maybe our AMR champions, Dr. Kinuthia, I think I will ask you to address this question on the strategies we're having to reduce this.
Sorry, thank you, Dr. Amina. Yes, so we have our AMS guidelines and AMS policy that requires that for antibiotics, you need culture and sensitivity results, especially for our reserve antibiotics. A few years ago, I think 2018 or so, we issued a memo on the same. We gave a list of what our reserve antibiotics are, and then we were what is required. So the question is, why do sometimes pharmacists give even without culture? So the guidance we had given at that point is that we need, apart from having culture and sensitivity results, we need infectious disease specialists review. So our guide was that we can give a dose as we wait for the review to be done if it has not been done. But ideally for our reserve antibiotics, we should have culture and sensitivity results. Yes, I think in summary, that's it. Probably at some point we can also talk more about prescription of antibiotics. Thank you.
Thank you. Another question from Julia. What do you feel about substitution of oral drugs for IV drugs in view of efficacy? Assuming she's asking regarding antibiotics as well.
Oh, okay. So as part of guidelines, there's sometimes the need to substitute, not really substitute, but change from IV drugs to oral drugs. Now, if we all remember our pharmacology, there are different situations that require us to use IV drugs and other different situations that require us to use oral drugs. So if a patient, considering all those factors, needs an IV drug, then you go that route. Of course, we have to also remember issues of injection safety and the harm and the challenges that come with use of IV drugs. But ideally for antibiotics, if a patient is able to take orally, and their condition also is, they're in a state that they can be treated on oral medications, they should get the oral medications. Most of the antibiotics, you'll find that their bioavailability, the oral bioavailability will be the same as the IV bioavailability. So to avoid the complications of injections and to basically promote injection safety, then that's when you're able to switch from IV to oral medication. So I think it would be on a case-to-case basis, but generally if a patient can take orally, you go for the oral medication, so long as the bioavailability is good.
Thank you very much, Dr. Kinuthia. So just to demystify this, myth that if I get paracetamol IV, my pain will disappear faster than if I take it orally. Maybe just touch on that, because there's that preconception that there's better bioavailability, maybe, but maybe you can touch on that, because there's that misconception that it works better if it's IV than if it's actually oral. Over to you.
Yeah, so just like I've said, you may not need to take an IV for you to get quick results, especially. So like using your example, we have, formulations of paracetamol that actually are, they get, absorbed quickly and they give you a quick response. So it's not always it's not for all drugs that you need when you need a quick action, you have to go orally. Of course, disclaimer is that there are some things like if you need, one of the reasons we give IV drugs is so that we get a quick response, but it does not apply to all medications.
Okay, thank you, Dr. Somebody has asked, how can I follow up on the webinar on the YouTube or future reference or study purposes? I think you can just go on YouTube, click KNH Research Department, and you'll see most of the webinars. And also you can go to the official website of KNH to access it. To end the discussion, I'd like to give a few minutes to Dr. Dorothy Ewak. We are very privileged to have you today to give an overview summary of what's happening with the CPD points for pharmacy.
Okay, thank you, Dr. Amina. With regards to the tokens, we have been relying the last financial year a lot on Daktari Online to support the mass mailing. However, at some point they stopped sending them, but we were not aware until recently. So we are waiting through the Research and Programs Department to find an alternative mass mailing system. So in the meantime, we are maintaining the registers. And as we are not too sure when is the last date they mailed, we are going to, when we have that system, we'll mail afresh the points from all the registers that we have. So we request that people be patient. What it is we said we'll try and work on is for the conferences, If that mass mailing is not there, then to organize for the conferences to get a volunteer to be able to support that. But for now, we encourage you just register. We have the attendance registers, and once mass mailing is approved, we can now dispatch those tokens. Thank you.
Thank you very much, Dr. I think that communication is timely, as mentioned by one of the participants. Unless any of the panelists have any parting shots, thank you very much, Dr. Weru. Any of the panelists, maybe you can have a parting shot.
So I think we can just appreciate the role that each of us has to play in terms of managing medicines and to support pharmacy, because this is not just a pharmacy affair. If we all work together to manage the medicines that we have better in whatever sphere we are, in whatever our area of practice is, I think we will be able to provide better quality care to our patients, and that our patients will actually get or derive great benefit from the care that they receive, not just in KNH, but even in the institutions that we work in. And I hope that for those working in different facilities, other hospitals, whether they are county referral or they are county hospitals at whatever level, from whether in public or in private, that there are a few things that you have learned from what we are doing here that you can pick and take home and be able to apply in your own setting as we continue to engage and share best practice, because we also can learn so much from what others are doing within their facilities. Thank you.
So thank you very much, Dr. Irene Weru, for the very informative session today. Thank you for shedding light on areas of collaboration. I hope after this webinar, we'll have a lot of reports, even if for the medicines that are not the best, I guess, in not so many words, we can be able to fill those forms, and we can be able to have more discussions. So thank you very much. So we've come to the end of the session today. We'll meet again tomorrow. Thank you very much, people. Bye-bye.